Friends, a very good evening to one and all who have assembled to witness the most eminent global and national scientist, the person who has brought in the field and science of peritoneal surgery, the person who has been associated with the neurological sciences for the last 4 decades and now is privileged to head the National Medical Commission Research and Ethics are with us. And I thank President Dr. Aman Goel for helping me to assemble the program, which has been a very special program for the so far IAGES Prime Time has seen. Ladies and gentlemen, now I take the privilege of introducing Professor S.P. Somashekar to you. Professor S.P. Somashekar is a very eminent and senior surgical oncologist from southern part of India, Bengaluru. He heads the Department of Surgical and Gynec Oncology at the Manipal Comprehensive Cancer Center, which is a part of the Manipal University and Manipal Hospital, Bangalore. He is the director of the HIPEC program, one of its kind in South Asia. He also has a very eminent interest in the robotic surgery, and he also heads the fellowship program of the robotic surgery at Manipal University. He has a very illustrious academic career. To further the MCH Oncosurgery, he obtained from Regional Cancer Center, Ahmedabad, with the best outgoing, and he was the University Gold Medal winner. He is a fellow of the Royal College of Surgeons of Edinburgh, editor-in-chief of the Springer Indian Journal of Gynec Onco, council member, International Society for the Study of Pleura and Peritoneum, honorary secretary, Indian Society of Peritoneal Surface Malignancy, and he heads the most prestigious, largest HIPEC and PIPAC program in India. And he is also contributing to the as a director to the Board of Studies of the Manipal University. And to his credit, he has more than 300 original reviewed publications in both national and international journals. Presently, he is the professor and head of the Department of the Surgical Oncology, and he takes care of both academic and administrative responsibilities of the Cancer Center. Ladies and gentlemen, may I have the honor of presenting Professor S.P. Somashekar to you. Dr. Somashekar, kindly take over.
Thank you very much. But the honor of the day is the legend. You know, we all, when we started our surgical oncology program, we all studied Professor Paul Sugar Baker's original work. And, you know, it was an honor for every student of surgical oncology, peritoneal surface malignancy, GI onco, and gynae onco to be able to even ever hear to Professor Sugar Baker. And he has a very fond association with India. He's a great teacher. He travels a lot to help people and the country set up peritoneal surface program. And he loves India. You know, we always fondly say India is his sort of second home. And he has visited India several times. And he has helped a lot of young scientists, associations, people, organizations to build up and envisage the dream which he saw and which he made it reality in the field of peritoneal surface malignancy. Professor Paul Sugar Baker is a FACS and FRCS. He graduated from Cornell University Medical College from New York City. He received his surgical training at the Peter Birmingham Hospital, Boston, which is an associated allied teaching program of the Harvard. And he also got a master's degree in immunology at the Harvard. Way back in 1976, he accepted the position in the National Cancer Institution in the surgical branch. Eventually, he became the medical director of the Washington Cancer Institution at MedStar Washington Cancer Hospital in the year of 1989. And he is the chief of peritoneal surface malignancy program, director of the GI program at the Washington Hospital Center in Washington, D.C. More than that, his area of interest is in field of GI cancer, gynecological malignancies, peritoneal mesothelioma. Wherever there is a peritoneal metastasis, that is where his virginal thinking, research, applications came. He's sort of regarded as the father of the HIPEC program and peritoneal surface malignancy across the globe unanimously. And you know what is most important for us to know is his mantra is, it is not what a surgeon actually sees that kills the patient, But what we are not able to hear and see, a surgeon cannot see, is what actually kills the patient. So this summarizes his thought process of role of intraperitoneal chemo, heated chemo, and the HIPEC program to bring cure and increase the excellent quality of life and overall survival in the field of peritoneal surface malignancy. He is also Secretary General of Peritoneal Surface, Oncology Group International. He has published over 1,000 original papers in international peer-reviewed journals. He has edited excellent 7 books, which are like textbook, which is there in our university library. All the medical college, surgical oncology has these books, and 27 original state-of-art videos, which are available on YouTube, which is the backbone of any peritoneal surface malignancy course we start with. And then he also has 4 honorary professorships. More than that, he is a mentor, inspiration for all the HIPEC surgeons, young scientists association globally. It is our honor to present to you Professor Paul Sugarbaker. Welcome, sir. The stage is yours, and we are all ears to hear from you. Welcome.
It is certainly a pleasure to interact with this group. Thanks for inviting me to participate, and thanks to all your participants for giving up their Sunday afternoon or Sunday evening to participate in this event. I might just make a quick comment regarding the introduction by Dr. Kanagawa regarding this super specialty. And yes, it is a super specialty, but I have to say that in order to be, and Dr. Shomashenko, you know this, in order to be a peritoneal metastases surgeon, you've got to know surgical oncology and general surgery from top to bottom. Although it's highly specialized, it does take a wide variety of experience in order to succeed. If I could have the next slide. I don't have any disclosures. Next slide. So this is just a quick outline of what we're going to be talking about today. We're going to focus on the origins of cytoreductive surgery and perioperative chemotherapy. Now, for me, perioperative chemotherapy is HIPEC. It's EPIC. And now we're getting more and more into the long-term combined intraperitoneal chemotherapy and systemic chemotherapy. We started out with a randomized controlled trial back in '85. Then we, for some lucky reason, focused on pseudomyxoma, and that was a great success story. We invented these 6 peritoneectomy procedures, and that described a phenomenon, but then we quantitated that phenomenon with our prognostic indicators. I think we have to give the Dutch great credit for their randomized controlled trial that was originated by my colleague Frans Zoltmulder. Then these multi-institutional studies that the French published, extremely valuable. Brendan Moran, and we'll talk more about the learning curve, but we have to be patient with ourselves in this new discipline, because we've done a lot of things right, but there's a long way to go. We have made it into the NCN Guidelines for colorectal and appendiceal malignancy, and that's good. I think our future is, for the most part, in diseases that have free intraperitoneal tumor cells, like ovarian cancer. And right now we're involved in a consensus as to how to come up with the proper HIPEC. Next slide. So I think that it's only fair to credit the National Cancer Institute biomedical branch and Bob Dedrick to show us that drugs that are administered intraperitoneally in large volumes can be expected to maintain a significantly greater concentration within the peritoneal space as compared to the plasma. And Bob Dedrick, and I was working with him then in Bethesda, really was the first to demonstrate this pharmacologic advantage of intraperitoneal chemotherapy. Next. Picture of Dr. Dedrick. Now, another important aspect of this treatment is hyperthermia. And it's been a huge amount of work to show that the cell-killing effect of many anti-cancer drugs is vastly enhanced by elevated temperatures. Now, you can't just do it for 30 minutes, as been done recently in a trial. You need at least 90 minutes of heat in order to see this increased cytotoxicity. Next. So the very first HIPEC was performed in, of all places, Louisville, Kentucky, actually by a good friend of mine, John Spratt, also a friend of my father. And he performed a single HIPEC in a young man with pseudomyxoma peritonei. He called it thermal infusion and chemotherapy. And he treated the patient once with melphalan and another time with thiotepa. I'm sorry to say we have no idea what happened to that patient, and we don't have any idea what happened to his apparatus. Next. So this is a picture of Dr. Spratt working in Louisville, Kentucky at the Cancer Institute there. 1980, long time ago, the first HIPEC. Next. So this is the apparatus that Dr. Spratt invented. It's very similar to our HIPEC machines today. There's a pump, there's a water bath and a heat exchanger. It really was what he invented is very similar to what we use today. It was part of a PhD thesis back in the University of Missouri, which is actually where my father practiced. Next slide. So I think the first bit of important data that showed that we could control cancer on peritoneal surfaces comes from this randomized controlled study that was performed at the National Institutes of Health. Was only 66 patients, and they were treated with EPIC and then long-term intraperitoneal chemotherapy. It was a very high-risk group of patients. The patients that got the prolonged intraperitoneal 5-fluorouracil had a very low incidence of peritoneal metastases, whereas the group that had similar doses of intravenous 5-FU, they had a very high incidence of peritoneal implants in this small group of patients. There was not a survival difference, but I think we showed that the natural history of surgically treated disease could be changed. Next. This is a picture of me somewhere around 1985. Next. So I'm not quite sure how we got to pseudomyxoma peritonei. There is a story that goes about that, and a couple of patients who came to the NIH kind of demanding treatment. And we did our first peritoneectomy procedures and then the EPIC chemotherapy. It's amazing to me that some of these patients treated way back in the late 1980s with pseudomyxoma peritonei are still alive. This is a curative approach to a peritoneal surface malignancy, and there's a lot of reasons why it works with the pseudomyxoma and the low-grade mesotheliomas and ovarian malignancies. But this was, I think, the first real success story, the first cure of patients with peritoneal metastases. Next. Go back one just a minute. There we go. We found out early on that putting chemotherapy into the peritoneal space with a large volume of tumor was not of any help. And the next major advance over the invention of intraperitoneal chemotherapy was the peritoneectomy procedures. 6 different procedures used to strip cancer from the parietal and visceral peritoneal surfaces. We all know that this is basically the starting point for a long-term benefit for patients with peritoneal surface disease, and this is true throughout the peritoneal metastases experience, the pseudomyxoma, colorectal, gastric, certainly ovarian malignancy. So the peritoneectomy is the standard of care. Next slide. And these peritoneectomy procedures are usually paired up with some visceral resections. And again, to make the point that I made as we started, this is a combination of peritoneectomy and lots of good, sound, general surgical procedures. Next. These prognostic features were described, and they're extremely important. The low-grade tumors, the appendiceals, do better than the colorectals. The histology, the histopathology is still crucial when you make a decision as to whether to treat somebody or not. Of course, complete resection must be the goal for all of the surgery. It's just amazing what a difference lymph node positive makes over lymph node negative patients, and this is true in the appendiceals and the colorectals and the ovarians. And then the volume is extremely important. Next slide. And we all need to learn how to use the peritoneal cancer index. Not going to go through that at this point in time, but it's 13 different abdominal pelvic regions and a size in each region, and you can come up with a score between 1 and 39, and it makes a huge difference as to how patients do. There are the parietal peritoneal regions and then the visceral regions that must be considered. Next slide. CC score is, of course, important. The goal of all cytoreductive surgery is complete cytoreduction. And for pseudomyxoma, it's okay to go to CC1. But when you're working with colon cancer or ovarian cancer, the goal has to be CC0, and that is no visible evidence of disease. Next slide. So we came up with what's been called the Sugar-Baker procedure. That's knowledgeable patient selection, complete removal, use of peritoneectomy, perioperative chemotherapy, and very important, all of this is finished as a single procedure. Next. The randomized controlled trial of Zoltmold is important. Next. This is Franz Zoltmolder working from Ziekenhuis in Amsterdam, von Leeuwenhoek Ziekenhuis, and Franz deserves a lot of credit. Next slide. For conducting this randomized controlled study. We're all familiar with it, but it really got things going in colorectal cancer. Next. The multi-institutional study that Olivier Glehen and I reported, extremely important, showing that we could get a median survival out to 32 months if we had a complete cytoreduction. Next. This is Olivier Glehen, currently chief of surgery in Lyon. Next slide. And finally, Brendan Moran, I think, deserves a huge amount of credit for telling us that this is something, this is a process. Next slide. This is a picture of Brendan Moran. We all know him quite well. Next. And I don't want to belabor this data, but in his first group of 30 patients, they had an 18% mortality and a 15% reoperation rate. And then as they went on, the procedures became safer. And it is extremely important that we try and monitor what's happening with the peritoneal surface oncology extremely, extremely carefully. Next. Next slide. This is the work of Wilhelmina van Driel and the Dutch ovarian cancer study. I think this is the most important study in peritoneal surface malignancy that's been published. There's a number of reasons why Wilhelmina succeeded here, and perhaps we could contrast what she did to perhaps the Prodigy 7 trial, and as to why one worked and the other didn't. There's very straightforward reasoning there. Next. Picture of Wilhelmine now conducting a randomized study in primary ovarian cancer. Next slide. So we had a series of Soji meetings starting in 1998, and we're going to try and have one in 2021 in Beijing. Whether that'll happen or not, I don't know. Next slide. This is important for us in the US. The NCCN Guidelines 2017 stated that their panel suggests that complete cytoreductive surgery and intraperitoneal chemotherapy can be considered in experienced centers for selected patients. Wow, we could talk the rest of the evening about selected patients and with limited peritoneal metastases. But it is an accepted treatment here in the United States, and I think around the world. It took us a while to get there, but we definitely are there. Next. Finally, invite you to Beijing, September 12 through 14. Next slide. I think that's it, and I'm open for any questions, Dr. Shomashankar.
Thank you very much. It's a fantastic talk. But I just know that you really need minimum 1 to 2 hours to just get into the history. We have heard from you. but for a varied group of audience, this is something which stimulates and takes through the major landmark. That's excellent. Thank you very much for this outstanding talk, Professor Shugabekar. To start the ball rolling,
yes.
As a student who picked up from you and made it a successful program in India, and many people now have started across the globe. As you told, when you started the HIPEC program, you never saw that probably appendixes and pseudomyxoma was something which would be the super hit. Then came the colorectal and then the gyne-onco. With your vast 40 to 50 years experience, 5 to 10 years from now, where would you see the HIPEC program? Like if you look back, you just like fast forward 10 years from now, where do you think the globe would position the HIPEC, and what would be the scenario? How would you foresee it?
Okay, very good question, Dr. Shomachenko. Kind of start with the beginning, pseudomyxoma peritonei, that will continue, and I think that our HIPEC will get a little bit better as we learn how to use perioperative Folfox. Not the quick chip that the French use, but a true perioperative Folfox. Convinced that we will continue to have great success with pseudomyxoma peritonei and basically all of the appendiceal malignancies. Now, what about colorectal? Well, right now, if I look at my data for the lymph node negative colorectal cancers, we have better than 50% 10-year survival. As soon as the lymph nodes are positive, it goes down to less than half that. We really need to work on the selection criteria and the perioperative chemotherapy for colorectal malignancy. It's there, but the HIPEC definitely needs to be improved. Ovarian malignancy, it's going to become standard of care. We need another randomized study, but whenever you have lots of free intraperitoneal tumor cells, like you do in ovarian cancer, that's where you're going to get the big benefit from HIPEC. Free cancer cells, HIPEC will eradicate them. Cancer cells that have been vascularized, that are in lymphatic channels or organelles, HIPEC is not so good, some effect, but it needs to be improved. But anytime you have these free intraperitoneal cancer cells, as with ovarian malignancy, you're going to have a success. Mesothelioma, much bigger disease, I think, in US than in India, but we have spectacular success with mesothelioma, with now HIPEC and then the long-term intraperitoneal chemo. Those patients used to all die within a year. We are seeing now 70% long-term survival with the mesotheliomas. So we've got the surgery. Now we need the magic bullet. And the magic bullet is that combined intraperitoneal and systemic chemotherapy that's going to preserve that surgical complete response. So that's what I'm looking for, is something that will preserve my surgical complete response.
Super. I know you're a great fan of EPIC, because you not only do a fantastic surgery and do HIPEC, you do put the catheter and follow it with the post-operative early chemo. It is quite tough for us to see how HIPEC and EPIC really do. How do you really foresee? Because you have done, and the excellent result you produced, and the Japanese and the Russian trials in gastric cancer with catheter-based chemo immediately after surgery is fantastic. But as a science, how do you say HIPEC and EPIC we can integrate? How does it really, what is your philosophy?
Good question. Good question, because EPIC is very confusing to a lot of people, and it is also not so, as we say, user-friendly. In other words, it's not given in the operating room.
Yes.
However, we've changed EPIC now quite a bit. The first round of EPIC, so we've done the cytoreductive surgery, we've done the HIPEC, we've closed the abdomen, we leave a little catheter in there, and the first cycle of EPIC goes in the operating room, stays there for 24 hours. The drugs that we use for EPIC are very carefully selected. It's either paclitaxel, which has this spectacular area under the curve advantage, or the other drug that we're using now frequently is what's called Doxil, or pegylated liposomal doxorubicin. These nanoparticles are very exciting in terms of their ability to find their way into a tumor and then slowly over the course of time release the drug into the tumor. So I see the EPIC as the start of long-term combined intraperitoneal and systemic chemotherapy. And the protocols that I'm working on right now, they don't just start with HIPEC. I always say HIPEC is necessary, but it's not sufficient. So we start with HIPEC and we get the EPIC going. We have all the little catheters in place. And for example, with the mesotheliomas, they'll get 6 cycles of combined intraperitoneal pemetrexed and systemic cisplatin. We need to get the medical oncologists to buy into some of these regional treatments. They hate the intraperitoneal ports. We don't use them anymore. We use intraperitoneal PICC lines. So I think we're going to be able to work through some long-term intraperitoneal chemotherapy treatments. I look forward to coming to India and showing you how I initiate this long-term combined intraperitoneal and systemic chemotherapy.
Absolutely. I have to ask this next question because a lot of GI surgeons, colorectal and gynec onco have logged in to hear this. What is that happened in OV HIPEC trial vis-a-vis Prodigy 7, which made it spectacular? The first question is, how do you interpret Prodigy 7? I know we have debated a lot. Have you now reserved yourself to PCI between 7 to 15? What is your message to all the HIPEC center like ours? Prodigy 7, what message should we take it from him, from a new HIPEC centers?
Yes. Extremely timely question because the manuscript was just released this week. Yeah.
Yes, we read that.
Yeah. So, first of all, it depends a lot on how you interpret the data. If you look at their figure 2 and you recalculate it, you will find that there is a significant disease-free survival, 0.04. Just have to look at the figure and you can say, my gosh, these lines are separated. And it's 0.04 disease-free survival advantage. Then you look at the survival curve, long-term survival curve. You have to realize that 16 patients, over 10%, crossed over. You don't read that in the paper. They crossed over between the non-HIPEC to HIPEC.
Yes.
If you put those in the HIPEC group, you have a 13% survival advantage. 13% survival advantage with HIPEC. Now, you don't see that unless you recalculate the data, and the trial does not allow you to recalculate that data. But I think there's a significant amount of positiveness, in the Prodigy 7 study. That's one side of the coin. The other side of the coin is it's a terrible HIPEC. It's 30 minutes. Only 30% of the drug is resorbed. In other words, most of the oxaliplatin that's put into the abdominal cavity is just washed out again. Nothing happens in 30 minutes. There's no hyperthermia, and the oxaliplatinum itself is a terrible drug. It's a terrible drug. You have to use it with a full dose of fluorouracil, which is what we do with our perioperative Folfox. We have 1,600 milligrams of 5-fluorouracil as a part of the HIPEC and EPIC, and then we have 200 milligrams per meter squared of oxaliplatin. Extremely well tolerated. We've treated about 20 patients now with the intraperitoneal Folfox, the perioperative Folfox. So, you know, if you're going to travel on a long journey and you go in the opposite direction, which is, I'm afraid, what the French did with this HIPEC trial, you're not going to get the answer that you want. I will say this, the French did a good job of showing that 30 minutes of oxaliplatin was not effective. Did they convince me at all that 90 minutes of mitomycin C with continuous manipulation of the abdominal and pelvic space was not effective? They didn't convince me at all. I think I have to be very careful for political reasons. I think that the trial was started in the wrong direction, and it came up with the result that I would expect. Unfortunately, Dr. Shomashankar, you've been in research a long time. You know that bad data is worse than no data.
Absolutely.
And unfortunately, we have a lot of bad data now that we're going to have to deal with.
Absolutely. And before I hand you to Professor Kanagavel, who will take a lot of questions from the audience which has come online, I have to ask you, I know everybody published open technique versus semi-open or closed is all same. I even read the Milan consensus statement which showed it is fine. But I want you to give a message. What technique do you follow? Do you follow open, semi-open, or a closed? Personally.
Yes, personally, I don't think that the, quote, chemotherapy aerosols are of any occupational hazard. So I use an open technique with the skin edges pulled up onto my self-retaining retractor, and I manipulate continuously through the surgical procedure with the whole abdomen at 42 degrees. So I would love to see a trial of a large number of patients, open versus closed, because I'm convinced that the mechanical aspects of the open technique are far superior. With the data that we have now, you can't really say one is superior to the other, but I don't see any disadvantage to the open technique in terms of hazard. And there's a huge number of theoretical advantages for the continuous manipulation, the uniform distribution of the heat and the like. So I, except for the drug melphalan. Now melphalan is a neurotoxin, and when I use melphalan, and by the way, I use melphalan a lot for resistant cancers. Then I will use the closed technique with lots of abdominal compression to try and move things around. So the only time I'll use the closed technique is with this dangerous drug, melphalan.
Fantastic. I will ask a last question before I give to Kanagavet. Your personal preference of restoring the anastomosis before HIPEC or after HIPEC? I'll tell you why. One of my team member, Dr. Rohit, he presided over a prospective comparative study at my institution, which over 300 HIPEC patients of doing a anastomosis before starting the HIPEC and bowel anastomosis after HIPEC. And what is your personal preference? You restore all the anastomosis and then do the HIPEC. What is your message on this?
You know, I used to do the closed technique long time ago, and I looked at my data, and I found that 1 out of 10 patients had a suture line recurrence. When I just published data, Franz Zoltenwolder's the first author, but we had a rather high incidence, I think it was 11% incidence of suture line recurrences when we performed the anastomoses prior to rather than after the HIPEC. So as soon as I saw that data, I said, I'm always going to do the HIPEC first and make sure that I debride. You know, I really rub these peritoneal surfaces. I don't just swish it around a little bit, but really move that chemotherapy solution around and make sure those bowel ends are absolutely clean. And since then, I have not had suture line recurrences. By the way, if I open a patient who had, say, a peritoneal metastases in the past, the most common site, a patient who has known peritoneal metastases are coming now to me for treatment, the most common site for disease is the old anastomosis.
Wow, that's a fantastic method.
So, and that's without any, of course, that's without HIPEC. But those cells, those free cancer cells, they love to stick into the sticky surfaces, the surfaces that have inflammatory exudate and blood clot and that sort of thing. So I always do the anastomoses last.
Fantastic.
But I don't do any diversions now. I do the sugar baker 2-layer stapled colorectal anastomosis. That's been very helpful.
Yep. Thank you very much. Excellent. Excellent. So, Professor Kanagavel, over to you to take the questions from the audience.
Thank you, Dr. Somashekar, sir. I think you were able to cover many questions from the floor also. Professor Sugarwacker, I have a couple of important questions. One is, sir, with your 4+ or 5 decades of exclusive peritoneal surgery work, a head-on situation, according to you, if you have the option to choose cytoreductive surgery or intraperitoneal chemotherapy, what will be your take?
So you're asking me to make a choice between intraperitoneal chemotherapy and cytoreductive surgery?
Yes, sir.
Okay, so let me respond in this way. I see the successful treatment of peritoneal metastases as a combination, a combined treatment of cytoreduction down to no visible evidence of disease, and at the same surgical procedure, a HIPEC or HIPEC plus EPIC, depending on the diagnosis. So I would not be able to choose one or the other. I'm always using both. The sugar baker procedure has the cytoreduction first, then the HIPEC, and then the reconstruction with anastomoses and abdominal closure.
So in one line, can I take it as the combination strategy, which is the most efficient one for the patient as an individual? Am I right, sir?
That is correct. Yep.
Perfect.
Yep.
And one last question before we close. There have been many questions on management of peritoneal disease in presence of a resectable advanced gastric cancer. Yes. People have asked for surgical primary resection along with the cytoreductive surgery, or primary resection with HIPEC, or PSA alone. What is your choice, sir?
Well, that's a good question. A very good question. For me, there is abundant evidence from randomized controlled studies to show that serosal positive, that's T3 or T4 gastric cancer, is likely to fail in the peritoneal space in 60+% of patients. So if I have a primary gastric cancer, I will do the best extended D1 or D2 resection, and then I will use HIPEC with primary gastric cancer. And in the U.S., that's pretty well accepted. A large number of institutions and approved by insurance companies and the like. Now, there is this randomized controlled study that's still going on in France. We await the evidence there. All the studies to this point in time are in Asian countries, but primary gastric cancer with serosal involvement or with positive cytology should have whatever gastrectomy is indicated and chemotherapy washing with HIPEC. And I would use cisplatin and docetaxel, 2 drugs, heated.
Thank you, sir. This is definitely not a technical question. You have come through an era where people, I would say, believe peritoneal surgery is not going to work or peritoneal disease is almost terminal. From that era, we are happy and to see somebody who can show 10-year survival. If you can tell a message for the young surgeons who are just getting into the career or aspiring to come into peritoneal surgery, what should be their vision and how do they approach the science as a whole for their career?
Okay, that's a tough one, Dr. Cabanal. Let me see what I can come up with. The young surgeon, number one, you've got to believe that these diseases can be cured or significantly improved in their outcome by this major surgical intervention. And we're talking about 10, 12, and the other day, 14-hour surgical procedure. So you really have to believe in the potential for cure. And a lot of young surgeons are just don't have that sort of dedication. So first of all, it's an attitude towards it. The second thing is, I think that if you're going to get into it, and Dr. Shomashankar, I think, would agree with me on this, you really have to have a research-oriented practice. In other words, you're critically evaluating whatever you do with these patients in an ongoing basis. And that's not only survival, but also adverse events. And we've been monitoring the pharmacology of our regional chemotherapies on almost every patient. So I think that continuing research is something that you should be committed to in wishing to become a peritoneal surface malignancy expert. Other than that, I would say we probably got another 4 decades to go before we really know what we can do and we can't do. Shomashankar, I think you would agree with me. The selection of patients is probably more important than the type of HIPEC or EPIC. It's who you're bringing in and who is likely to have a success. So we're learning a lot. I'm learning a lot because I'm right now in the process of evaluating 40 years of data that we've accumulated. And I'll be continuing to work towards trying to make this more successful and less toxic for patients.
No better answer for this. I always say there are 2 types of people in the world. One who believe in evolution, Darwin's evolution and revolution. you don't take challenge onto yourself and believe somebody else will bring a revolution. No, wrong. The peritoneal surface malignancy treatment is for people who want to take challenge head-on way, make your own path, believe in revolution, which world follows you. You need to have the passion and science go together, audit yourself and your team so you improve. Like I remember 7 years back we started, and what then we are 5 years back. Today we are totally a different group now. So when we audited our Indian registry of HIPEC of 2,200 patients, the first 3 years and last 5 years are totally different. You have to be one of those person who takes it as a passion, revolution, and try to bring a revolution, not wait for an evolution. This is the most exciting field, I would say, for a surgical onco student. And if they don't take this path, they really miss a lot in world.
I think I only wish I have more time to interact with losing the highest intensity at the end. I'm sure we have had the honor of listening to both the eminent peritoneal surgeons and the father of peritoneal surgery. I would love to say Professor Sugarbaker. Now, I would like to invite our national president of the Indian Association of Gastrointestinal Endoscopic Surgeons to do the honors and to give the formal thanks to Professor Sugarbaker for his great contribution of wisdom and inspiring the young surgeons into the toughest specialty of this part of the surgery. Dr. Raman Goyal, over to you, sir.
Thank you, Dr. Kanagvel, for inviting the creator himself, Dr. Sugarbaker, who created the path, as Dr. Somshekhar said. It's always very challenging to think of something so different than what everybody is doing, and to be research oriented in surgery. It is really a challenge to do something different and something which is back-breaking, time-taking procedure. So it has been a great honor. It's not about the young surgeon. I am also quite young at 62, but it was an eye-opener today. Last 45 minutes, what I have learned is probably what I should have learned 45 years back, and I would have been in peritoneal malignancy surgery. So I'm so glad that I'm here to attend this and to listen to both of you and your interaction. Absolutely amazing. Thank you so much, Professor Sugarbaker. We would love to have you in India very soon as the COVID allows us to meet again. And I would love to meet you in person. And thank you, Dr. Somshekhar, for facilitating this interaction. Pleasure to see you in person. Thank you so much.
Thank you. Pleasure.
Friends, we move on from this high-intensity, research-oriented program with a lot of data to something which is very basic. And this is on medical ethics in clinical practice. And I think this has come at the most appropriate time when COVID has exposed all the possible fault lines in healthcare. And this is the time when we are talking to the person at the apex of ethical issues in the country. I am talking of Professor B.N. Gangadhar. Professor B.N. Gangadhar is the president of Ethics and Registration Board National Medical Commission, which, as most of us know, has replaced Medical Council of India. Professor Gangadhar is MD Psychiatry from NIMHANS, DSc, Doctor of Science, Fellow of National Academy of Medical Science, Fellow of the Royal College of Physicians, Edinburgh, and Fellow of Academy of Sciences. He is retired as Senior Professor of Psychiatry and Director of NIMHANS in October 2020, very recently. Professor Gangadhar has been awarded Sir C.V. Raman Award from Karnataka government in 1996 and Padam Shri in 2022. Besides these awards, he has 400 national and international indexed articles. His H index is 52, which speaks about his citations and his followership. And he has been a guide and co-guide to nearly 60 MD and PhD trainees for research. And his research areas are yoga, schizophrenia, public health, ECT, and others. So friends, it's a pleasure. Welcome, sir. Welcome to this platform for the first time, and we are very happy to have you on a issue which is bothering so many surgeons across the country. And I'm happy to have you because I'm getting continuously questions from last 2 days from so many participants who are attending today. And I have so many questions that if I have only a rapid fire round, that will itself take about 45 minutes. So friends, what we are going to do today is we are going to cover many issues which have been raised, flagged by many of you about patients' rights, the equity of resources of lack of resources and their distribution, confidentiality of the patients, patient safety, conflict of interest, something which is very close to my heart, ethics of privatization, informed consent, beginning and end of life, and the healthcare team. So, friends, we will start. Professor Gangadhar, welcome to IAGS. Shall I start? Go ahead.
Yes, sir. Please go ahead.
Okay. So, Professor Gangadhar, in your opinion, what are the ethical challenges which a doctor faces in modern times?
There are some concerns. I've been sitting in the ethics committee of the Medical Council of India, the Board of Governors. So what in National Medical Commission is 3 months old, but my role as managing the ethics issue has been little more than 2.5 years. Bulk of cases which are filed come from surgery, orthopedics, and gynecology, and the others maybe contribute to about as much, all other specialties put together. It looks like this is a big area where people confront the professionals. Now, amongst all the cases that I have heard, the commonest problem that seems to occur, why they go to Medical Council of India or the State Medical Council before coming to us, is some lack of communication and clarity between the doctor and the patient. That leads to, it looks like something is being hushed up. The lack of communication might have been inadvertent, but yet when a complication happens, they interpret this lack of communication as deliberate. Something was hidden from us, whether it is a complication of a surgery or the cost of surgery or lack of facilities that is making the procedure challenging, or an advanced stage of the condition which the doctor with good wish, good intent wanted to operate or treat. So it's a lack of communication which seems to be the root of the problem in most cases. In most cases. Yes, of course, there have been what we may call as unforeseen errors. Nobody is saying that the doctor did it on purpose. I don't think anyone would say that, but the fact remains that when error happens, and for various other reasons, it gets magnified. The common reason why it gets magnified is poor communication.
Okay. So we'll come on this medical legal issues. But one thing that I realized in last 1 year is that patients' right to healthcare is also an ethical issue. Right to receive quality care, treatment options, to know the treatment options, the privacy of their treatment, confidentiality. Is it an ethical issue? Somebody who can't afford a private healthcare and is not getting good quality healthcare in a public sector. Do you see it as an ethical issue?
Currently, no. I wouldn't say that since some treatment is not available in government sector, it's available only in private sector, and so somebody has to foot that bill. I don't think that's going to happen in the near future. What would at best happen is more and more insurance groups which would start covering them.
When the government of India has, in fact, covered many procedures under the Ayushman Bharat insurance scheme, which people are availing. Given the nature of the country, given the resources available, best healthcare should of course be given, but the definition of best seems to vary.
Okay.
Some of the facilities which are available in government sector, if you invest on one huge, I've been an administrator in NIMHANS as well. Some of the procedures where a treatment would cost close to about 3-4 lakh rupees. The government invests on that. You would probably be denying about 300 patients free medicines for a simple treatment such as epilepsy. So I think there has been a trade-off between some of these things, but hopefully, I'm very, very confident in the way in which it is going. The best treatment will also be available in the government sectors. And once those things will be available, maybe the insurance will allow all facilities be used, whether private or government. Right now, the match is not on an equal footing between government and the private sector.
Okay. So I'm going to talk a little broadly about the broad issues on ethics before we go on specifics. Professor Gangadhar, does the ethical issues apply only on a doctor, or does it apply on hospitals or institutions as well?
No, currently the Medical Council of India or the National Medical Commission registers the doctor. It doesn't register the facility. So I have no authority to find a facility. Some error has happened. But whereas I have only a right, the jurisdiction is only with the medical practitioners who are registered under the National Medical Commission. So this has come up many times. In many of our ethics questions, this issue keeps coming up, saying that we went to this nursing home, the lift was not working, and the patient was physically being carried up to place A to place B. And this led to his hand getting crushed in the window, which it struck, and he was unconscious. He didn't know. But only when we went to the bed, we saw that the hand had been quite torn because the cot was lifted physically up in the staircase. Now, what I'm going to tell you is this is not under the jurisdiction of the Medical Council of India or the National Medical Commission. So what we can advise is the doctors. If the doctor is an administrator of a nursing home, even then he comes under the Medical Establishment Act or whatever it is. It doesn't directly come under the manage. It is here doctor to patient with respect to that given treatment. Whether it is a surgery or whether it is prescribing a medicine or giving any other therapies that he is offering to the individual. Relationship between the doctor and the patient, is that what we have a jurisdiction to question?
Okay, because there are a lot of ancillary services like medical tourism companies, facilitators, private hospitals, which do not get covered, and they are also providing a healthcare service in a way. Anyway, so shall we move on? What do you feel about this Hippocratic oath in 21st century? Because now there are so many social conflicts have come in place, like how affordable is a good quality care. We just heard a good discussion on long 10-12 hour surgery and chemotherapy, expensive chemotherapy. So if a patient comes to a doctor for a treatment of a peritoneal metastasis, and if he can't afford this, the doctor is
I've already said that. Right now, it's not fair to make a comment on the ethics of that. That doesn't come under my jurisdiction.
Okay.
It's not fair to talk about what if the most expensive treatment is not available in the government hospital. Should somebody or the government itself allow this person to take treatment in that 5-star hospital? What if an average private hospital does not have it? How does a person going to an average nursing home and that treatment is not available, and that is the only surgeon that is available, and he or she would practice in the most expensive corporate hospital? How do you help the individual? These questions cannot be answered on ethics.
Okay, Malay?
Almost commercial.
Yeah, I understand this. Yes. So, what about the training of ethical issues to healthcare workers? In many developed countries, it's an important topic, and there are regular training programs and updates. So, is there a standard format and continuing ethical update program being planned by the?
Yeah, we are in the moment at this point of time. We are planning. I believe that in the medical curriculum itself for the medical graduates, there is a feature on ethics which is happening. We would like to make a module which is available on a tele platform where the doctors and practitioners, update themselves periodically on the ethics issues. But what we talk of ethics, we say what you are talking of ethics or the ethics in general, for example, confidentiality, consent, etc., etc., is one part of it. But almost always, what we face in these complaints by the patient is errors that have happened during the procedure. A wrong medicine was prescribed, a wrong surgery was done, or surgery, the medicine that was given to the individual had a very bad reaction. This was not explained. So some of these issues seem to cloud the other aspects of ethics. But I believe most doctors have become reasonably ethical in terms of the other issues, and confidentiality, in terms of consent, in terms of informing the individual. The rate at which people expect doctor to be transparent has been very favorably responded by our doctor profession. Most people do a very good job in this context. And there's, of course, an occasional individual where people were busy and the doctor took it for granted and somebody else would have counseled the individual, explained the matter. But by and large, I think our doctor profession has stood up to the expectations from the community.
Yeah. Isn't that more reactionary in the sense that doctors are responding to how the society is, what are society's expectation? But as far as training of doctors are concerned, or training of all the healthcare workers in terms of interaction with nurses, in terms of interaction with technicians.
You're right. Many associations, many groups have already been doing that. And in fact, sexual boundary violation, there is a format that we gave to one of the professional associations who have incorporated that. And then other non-sexual boundaries, how are you going to prevent crossing that during our interactions with the patient? That's again, a series of ethical concerns change from profession to profession. For example, psychiatry, there could be something else, and in oncology, there could be something else. And from profession to profession, there could issues which are going to be different. I totally endorse your viewpoint, whether we need to provide a formal curriculum for ethics, which actually has been provided, but the fact remains whether for those who have already been graduated, whether we need to periodically update them on the ethics. We, of course, have made a plan on this. This will be available on a digital platform soon.
Wonderful. So moving on to a more difficult area, the doctors and physicians are not allowed to advertise their services in India. This makes the young competent doctors at a disadvantage. It puts them at a disadvantage because word of mouth awareness takes time. So should we have a registry and display of outcome data as has been done in United Kingdom, so that the patient can assess the outcomes of doctors take a call.
This is an excellent point. In fact, I have been talking about it quite loudly, although it will be a little difficult. One of the ways of which I believe it could be planned is something, I'm going to take it up in different forums, is that a doctor's, what we may call as a curriculum vitae, will be available on the net in the, let's say, Medical Council of India or the State Medical Council, or the National Medical Commission or the State Medical Councils. So, for example, I am referred to Dr. X, and I want to know whether this doctor is good enough for me or not. I could get into this doctor's profile on the Medical Commission or the State Medical Council, where there will be some information that is available. The doctor, when did he pass out, how many years has been operating, what are his specialties, whether he or she got recently been awarded and recognized, he's got a new degree from which institution, XYZ institution. Were there any disciplinary action that happened to this doctor, etc., etc. A profile will be given, and the places in which this doctor practices, hospital X, hospital Y, hospital Z, and what is the, it's very simple thing. Like recently, I had to buy some product from one of the web sellers. So we look through what are the reactions on this product by so many people. A lot of things we do a search before we zero in on this product. My suspicion is, over a course of time, it doesn't start doing it. As it is, they're doing it. As it is, they're doing it, but mostly by word of mouth. But whether this can be made available online. So the doctor also know that it's a form of advertisement to the doctors indirectly. At the same time, the patients also receive a very transparent way of getting the information. But it's still at the thought level. Please understand, it is still not come into place. But there can be many other reactions to this. Many people may not want this. Many may want this. We need to see how the medical profession reacts to this degree of being transparent.
Yeah. So the GMC has this system where people put out their data, but that needs registries, national registries for most of the procedures, and then only you will have the data coming in. So probably what you're saying is not that easy to implement.
It's very difficult.
Scenario.
I agree. I totally endorse. There are some things maybe doable, but not all doable. Like man has done 100 procedures of breast cancer surgery, or this person has done 100 procedures on removing the thyroid. We have no way of accounting for this. This information we may not be able to put it.
All right. One of the important component of ethics is consent. And as most of us understand, consent is a constant procedure of providing information. But somehow it is being used more as a medical legal tool in India. So are you planning to somehow improve this consent as a tool of information sharing and shared responsibility?
Yeah, it is difficult to come up with one common consent format. There are several issues that are involved, particularly when a procedure involves multidisciplinary input. It may need a vascular surgeon, it may need a thoracic surgeon, it may need a cardiovascular anesthesiologist, and it could involve an imaging person. There are several people who are involved. The way in which the consent form has to be designed would vary from profession to profession. A common consent form is difficult to be provided by a general body like the National Medical Commission. The fact remains, the individual should be given information that it is not going to make him very fearful of the entire procedure. At the same time, the pros and cons have to be briefly explained. An opportunity should be given to the individual to question. Any information that is available in the net, those sites, these people should be allowed to access from wherever they are. Not all people will be good at accessing these things, but it is the doctor's role to make the patient be aware of all the places in which he can or she can access this information, and allow a day or two to let this person ask questions. The procedure is, whatever the treatment is, elective and it is not such a urgent issue. Urgent issues, of course, we have to communicate to the patient, and if the patient is not in the position to receive this information because he's unconscious or something like that, and we have to inform the family member and take the consent. First of the kin who is available has to be explained. Documenting all these procedures of having explained what are the questions they have asked as much as possible would reduce any penalty in the event of any complication. It may be a good news for all of you that the proportion of complications, the proportion of the complaints that we are receiving vis-a-vis the numbers of procedures that are happening in the community is rather minuscule. We are lucky that we have a very, very supportive and very docile or very encouraging group of patients who receive us very well. Given the numbers of procedures that are happening, the numbers of such complaints are quite substantially low.
Okay. Dr. Gadar, you are well out of the controversy all over the country over privileges of doctors from different fields of medicine. So is there any move to define privileges of each degree, what a MBBS doctor can do, what a postgraduate can do, what a Ayurveda doctor can do?
What a doctor is allowed to do in allopathy, I don't think we have prescribed it anywhere. I have been doing research for quite some time. Not sure if a Dr. X can, the MBBS degree, is he allowed to do a procedure which the gynecologists are doing, let's say hysterectomy, whether he is allowed to do or not. This privileging the professional qualifications has probably need to take place, but it is going to be very difficult. There are viewpoints where they say that once you have got an MBBS, eligible to practice, acquire competence on areas where you want to practice and go ahead and practice that area. Then the other people also say that where is the evidence having acquired this competence? Then the introduction of postgraduate degree. And what if there is a super specialist available? Would a general surgeon be allowed to do a cardiac surgery or not? So these questions are yet to be answered. I guess, for that matter, there could be other professions other than allopathy. People have prescribed, if you are trained with this degree, you're allowed to do only these surgeries, not anything else. This has been happening. I think we need to also learn from our side. If I have been trained for an MD dermatology procedure, what are all the things that I am allowed to do? If I am trained in MS general surgery, what is the limit beyond which I should not be doing? So these probably may come, but if they come, there are some pros and cons of that also. What if it is an emergency? Would he be allowed to do this? Would he have to do a burhole in an individual who has got an acute extradural hematoma or not? So these are all the questions which we probably have to face these challenges. There are some areas wherein the degree matters. For example, in radiology, getting a permission from the AERB to set up XYZ unit, you need to have a radiologist at the helm of affairs. So he has to have a training in radiology, which means either a diploma in radiology diagnosis or a MD in radiology diagnosis is required for that purpose of certification from the another regulatory body. But to report an X-ray and write a report that he had pneumonia or not, would MBBS be enough? Yes, I believe it should be enough. So these questions we have not, what should I say, made it so explicit that makes people confined to some very strict boundaries, and that has not happened yet. I don't know whether it should happen or not.
Okay. So, when I was reading about the ethical issue, adherence to specialty is an ethical issue, that you don't get involved into something else. Now, when there's a proposal for overlapping of systems like Ayurveda and homeopathy and allopathy all together, what do you think? Where will the National Medical Commission stand on this? Has it been discussed, or are you proposing to have glass walls between these different systems?
It's difficult to make any comment point of time. I think we need to engage ourselves in more discussions in the National Medical Commission before I make any comment on this.
Okay. Yeah. All right. So one of the concerns some people have raised, that how does one raise a violation of ethical practice? Do we have a whistleblowers policy or anonymity mechanism? So if somebody has seen a violation, where does he report, and how does he report without being identified?
No, we have no such provision at this point of time. Only the person who has been aggrieved can report. There are, of course, we get complaints saying that so-and-so has put a board bigger than what is prescribed in the State Medical Council's permission. He has, some doctor XYZ has written in bracket, he is a thoracic surgeon, whereas he has done only MS General Surgery. People send those things, but this is very difficult to act upon, because the person who is receiving the treatment only has an opportunity to complain. And when such things are happening, we of course have written to the doctor, look, this is not acceptable, you have to change. Let's say a board is allowed to be put in a dimension of 3:5. Each state medical council has a procedure to follow. They will have to abide by that, and I think that.
Okay. And
no whistleblowers thing in terms of, let's say, it has happened sometimes, but that investigation has not to the useful results. Like some law will come up to protect such act, like kidney organ thefts or whatever we were calling. That those things came to exposure only by the whistleblowers story. Laws have been brought in, and people now are aware. Now people can complain, and things have definitely improved over the course of time from the whistleblowers activity in medical ethics. But I think doctors also have to learn not to let whistleblowers get upper hand.
Okay. Dr. Gangadhar, I mean, all these violations have to be reported to State Medical Council or Commission, whatever it will be called now. Do we not have? Don't we delegate it to an institutional level? Don't we have a institutional ethical violation redressal system, which will make it clear?
Most medical councils, for example, if I am a patient, I was treated in some hospital X in, let's say, Aurangabad, for example. I report to I have a grouse against the doctor, the way he did the procedure for me. I report to the State Medical Council, that is the Maharashtra Medical Council. Maharashtra Medical Council, in its wisdom, might look at the whole thing. There are many other issues which are involved. They may ask for a report of the hospital if there is a grievance redressal in the hospital. Have they looked into the whole thing? Most likely, he would have reported to that hospital itself, and they would have made a report. And if that report is not, it's biased and it's not correct, there is a state health directorate. Have they looked at the whole issue? And if not, the State Medical Council has in its jurisdiction right to ask a separate body to investigate the whole thing and give a report. After getting the report, if the report finally says that there is nothing at all, they may still, the party may still want to push the issue in the State Medical Council. I want to be heard. State Medical Council will go through the whole thing, and if it that these reports are not very supportive and the patient actually is correct, and so a punishment has to be given, a doctor has been punished. The doctor has a right to take it to the higher level, that is the National Medical Commission, or leave it at that. If the patient finds that the doctor has been exonerated and the patient wants to reach the National Medical Commission, even then it's fine. But by and large, as we have seen, most state medical councils have been doing a very, very satisfactory job of going through documents, going through a third-party review like the Directorate of Health Services, and before making a conclusion about the right or wrong of the doctor. So the role of the National Medical Commission, the then Medical Council of India, was not really very big because we have collected all the information already. But we would still see if there are any fresh concern that the patient is raising. There are any other things that have been missed by the earlier state medical council. It is rare that a state medical council judgment is changed by the National Medical Commission, because the state medical councils do a very good job.
Okay. So, between the medical council or the state medical council and Medical Council of India, there is not much of a problem. But the doctors find it very difficult to understand the hierarchy of consumer courts, police action, criminal action, civil action, and medical councils.
Yeah, this is right, sir. Like somebody was commenting very over a cup of tea that the doctor is the most harassed person today in the country, because there is a violence against the doctors by the patient. This is one part of it. Second thing is harassment to the doctor, taking the individual to the police, where the police can file an FIR, can even say that you are going to be arrested. You go to the consumer court, you will go to the civil court, you will go to if it's a woman or if it belongs to some other category, they are also free to appeal to those bodies, Women's Commission, or they are also free to appeal to the State Medical Council, and sometimes they even write directly to the National Medical Commission as well. So the doctor is harassed from many angles. It's a good idea to have a hierarchy, but I'm not sure how, because each one operates in a different structure altogether. Each one has been given a different act. I'm not sure whether a hierarchical system has built in. He or she should report to the police or whoever is the law-making authority, who in turn have to guide the individual to go to the State Medical Commission or State Medical Council. So we need to come up with some methodology in which the doctors should be allowed to work as peacefully as possible, to be able to give as much service to the individuals as possible. Nonetheless, the rights of the patient should again not be curbed. They should be allowed, but it should not happen that he or she approaches many regulatory bodies who are going to be acting on the doctor as a professional, as a civil society member, and and so on and so forth. That is, in my personal view, we have to probably bring in some sort of a system. But I'm not sure whether in the current dispensation whether that is possible or not.
Okay. So I thought you are in the right place to make this happen in next few years. But Dr. Gangadhar, what do you feel about, you have been a part of the ICMR research group. We are finding it very difficult to do certain audits of our data, because for everything there is a ethical committee approval required. While for many just an audit of data, this should not be mandatory. So there is a blanket ruling that all the organizations and researchers, for every study or research, we need to get the ethical committee approval. So is it possible to make it a little easier to do certain audits?
In what sense? I still don't understand.
So this is like
you have to do an ethics committee clearance.
Yeah, so multicentric audit of whether it's retrospective or prospective audit in UK, as long as the patient's identity is not disclosed, they don't need ethical committee approval. But
I'm not sure, because ethics review in Indian Council of Medical Research is different from what ethics review which we do in the National Medical Commission. Here we directly act upon the individual who is registered with the National Medical Commission, his or her activities. But you are talking of a different issue altogether.
Yeah.
Talking of a totally different issue. I think it is wrongly posed to me, and I would find it difficult to make an answer.
Okay.
But, for example, as an administrator in the NIMHANS as a director, we had made a policy that anybody who is looking at the chart records for purpose of research, when they are doing the chart records, they have to give to the ethics committee, and this is what they will follow. Number one, they will not call the patient back. They are not going to telephone the patient about his or her condition. They are going to, if there are any data that they are taking from the records or from the system into their system for doing an analysis, patient identity, either the address or the name, they are not going to take, or even including the hospital number, they are not going to take. Some rules that have been named, and they have to give a statement that they will adhere to these things, and only the clinical data will be examined, whatever it is. So this is allowed in each institute. But if you are doing a multi-center such work, each center has to take permission from their center's ethics committee. And that should be possible. There is no reason why a chart-based audit or chart-based research should not be allowed. But to allow that also, it is not taken for granted. Once the chart is there, it's free for all. No, it's not. A person has to indicate why and what purpose he is using the chart, and what are the do's and don'ts of this individual. I think this is fairly well spelled out in most ethics boards, and I think they will follow that.
Okay. All right. So we are almost coming to the end of this conversation before Dr. Khanna will takes up a few more questions. One of the questions that was asked by one of the participants is about the end of life decisions. So do you think how far?
We don't have an answer yet, sir. This is entirely ethical, and it's a national level concern. Whether, it's very. There's no one word for that. There's no one schema that will operate on all these end of life diseases. Where what can I do? Should I withdraw, remove the ventilator, stop the? I have no answer for that. We don't have a written answer for this issue.
Yeah, but do you think that we are going to have it in near future, in a few years' time?
It requires a lot of consensus building. Different specialties have a different issue. I think we need to build consensus. I think each professional body, whether it is pulmonology, cardiology, neurology, all these people have to probably come up with, in their domain, what would be called as end of life. Where would they stop? So it could vary across different disciplines. So it would be very difficult for one body to be able to dictate terms to all disciplines.
Okay.
Each discipline should be with some consensus document, and maybe the National Medical Commission or the Ethics Board of the National Medical Commission needs to go through it. And I think an independent body of jurists or whoever it is have to go through the whole thing before we come up with a capsule on this issue.
All right. So now, Dr. Gangadhar, last fortnight, we have the National Board of Examination President and Executive Director here on the program. And they briefed us about what is in store, the reforms that are coming in NBE. Now, the same question comes to you. What is the NMC roadmap for improving ethical practice? So what do you have in store for us?
Yeah, we already have some clarity on this matter. We already have some clarity on this matter. 3-4 exercises have already happened, which is going to be put on place. Example, a common way of avoiding the disciplinary action. Each state medical council may be adopting their own mechanism. Whether we can find what are the issues and for what error, how we can grade the error, and how we make the doctor becoming responsible or not. How do we define that? The procedure, so-called SOP, and also the so-called doses of discipline that we have to administer to the doctor in terms of what has happened. There's some uniformity which we have arrived. There's a committee that worked in the earlier for 2 years ago when I was the chairman of the National Medical Commission and the chairman of the Ethics Board of the Indian Medical Council of India. At that time, a law person, some doctors, and other people sat together, made this document, and which is going to actually make things clearer than what it was earlier. Second, the way in which the trial will happen at the State Medical Council has to be made uniform across all states, for which we are going to be shortly having a national online meeting with all the State Medical Council, the Ethics Board people and concerned authorities, and see whether we can all come up with one standard format of the trial procedure as a standard operating procedure. And any appeal to the National Medical Commission will come only after the State Medical Council has heard and then given a verdict. And even if it has given a verdict, to appeal to National Medical Commission, the individual should have very clear reasons why he or she is appealing. New issues, some issues not being considered there, all have to be taken. And if some things that we should refer back to the State Medical Council, the Medical Commission should be able to advise in its group that these are the areas where we think you might have not really be fair to the patient or fair to the doctor. You go back and do a review once more. So these are the things that are possible. Reforms are already being in place, and I'm hoping shortly with the National Medical Commission holding this nationwide webinar, all state medical councils will be able to operate this even better. I think they are doing a very good job. Currently, all the state medical councils, the way they're hearing, the way they're thoroughly examining each individual has been excellent. I have myself seen the records of some of the state medical council reports, because we get the entire report to us when a person appeals to the National Medical Commission. Fairly exhaustive work could have been done at all the state medical commissions. So I think it's just a question of fine-tuning, making everything uniform across all states before it reaches the National Medical Commission.
Okay. So thank you, Dr. Gangadhar. That was quite enlightening, though there are many issues which remain unresolved, but I think this is work in progress, and with National Medical Commission being formed, is just a matter of time that many major reforms will have in the medical education and healthcare overall is concerned. So, Dr. Kanagvel, do you have any questions to ask Professor Gangadhar?
I will take the permission of Professor Gangadhar to take a couple of questions. A lot of questions are there, but then many were covered either partly or they are totally out of domain, as Gangadhar sir has very clearly defined his domain of expertise and willingness to address to the issues. Sir, one important thing, like people have been talking ethics as part of the medical curriculum, but predominantly ethics come into clinical practice at much later, once the postgraduate gets into a practice-based system, either in a teaching hospital or in his own practice. Somehow or other, as you rightly pointed out, there are multiple facets or multiple bodies which govern this ethics on various levels. So are we slowly inching towards shared decision making? Say, of a patient-centered treatment, mostly individualized approach, a good informed consent process also has been taken after a clear discussion of the benefits and risks as available. But still, the end of the day is the medical profession handing over the decision making to the patient and to the family for want of their legal safety. How are we to look up at this issue, sir?
Yeah, you are right, sir. The way in which each person applies those ethical skills could vary across doctor to doctor, depending upon each doctor's personality. There are some people who may think that the patient should get the entire freedom to make a decision, but some doctors feel that a partial freedom, but our experience should also be given to the patients in good faith to let this procedure happen. So there are pros and cons of both of these things. But I believe full freedom to the patient and good documentation of what we have explained or what we have done is a lot of times the trouble happens to the doctor because documentation has been poor. So I believe although it takes little extra time, it is useful to document most of the information that is communicated to the inpatient or patient which has communicated to him and the circumstances under which the whole thing was done. This will give a lot of protection to our doctors.
Thank you, sir. And the next important, I would say it is my question. Already it is part of the National Cancer Grid, where patient information are available for the professionals. Starting initially, it was the pathology. Now, clinical data are being also available. Sir, initially, when the Cancer Grid was formed, there was a proposal to integrate the clinical data or the treatment data or the outcome data to a patient security number. I'm sure the government of India is working for an identification number apart from Aadhaar-based system. Can one universal ID for all the patients, which implied or expressed access to the medical professionals, are they on the anvil, or how far we are away from an integrated one database for the entire country, sir?
Yes, sir. It's going to take a lot of time. As you know, Aadhaar took little more than 8 years. Still not totally available to everybody. There are some privacy issues, some commercial issues. It is going to be a challenging factor. The National Digital Health Mission has been set up, as you are all aware. The National Digital Health Mission, this is what it entails to do, that the patient data be available in some encrypted format, and with the consent of the individual, be made available to the next treating doctor. Whether this should be available ad libitum for purposes of national level registries of illnesses, national level trends searching, I am not very sure how it is going to happen, how people will react. People may not want to share this information to for these purposes, or they may want to. So I think we need to first make patients comfortable. The patient's clinical data is available every other place. With the consent of the individual, he should allow the treating doctor to access his medical records of whatever numbers of years he has. And the medical records of the patient should also be available to the patient, where if he wants to change XYZ area, the concerned doctor is put in, be informed. Look, this information I had not given and you have put in. So there has to be quite a degree of give and take and very dynamic way of maintaining these records, which is going to be a very Herculean task. But given that today information system has grown quite big in our country and we are ready for that, I think the National Digital Health Mission would probably accomplish most of these targets.
Thank you, sir. One last question from the floor. I'm sure this is not a common occurrence, but all of us at either intervention, either a medical interventionist or a surgical interventionist have faced a proper consent has been taken, a proper information has been given. In the process of doing a procedure, the surgeon or the physician feels like he is having some change in the approach, or he need to change to altogether a different procedure than what was explained to the family or to the patient. What is the right and safe way to handle this situation?
Yeah, I can understand your issue. I have started the procedure, patient is already under anesthesia, and you have to take a change of decision. The reasons why you are taking a change of decision, I would expect that the doctor documents it. And this change of decision could be unique to this given individual. No textbook could have written this. Because we treat the individual, not just the disease. So given that situation, documentation is a safe way of defending oneself. And most people, and after the procedure is done, it's a good idea to make full information be available to the patient. This is what we intended to do. And while opening, this is what happened and this is what we found. And we have changed this procedure. Instead of given stent X, I put some other pipe Y. I had to do this because this is what has happened. And this would mean additional cost. This is an area, it's a gray area. It's very difficult to control. We will not be able to control. But this is an entirely commercial wisdom of the doctor who handles this individual. The information has to be given. And if the outcome has been good, most people don't object. The occasional individual, yes, you are right. People can put the doctor into an embarrassed situation. But that is part of the game in a commercial scenario.
Sir, one final question. You have been into this journey of looking at various perspectives. When a human starts complaining about it, it obviously means the result is not gone his way, or as you rightly pointed out, the cost have got escalated. Something which is definitely not in the reach of the treating hospital or treating physician. An adverse result obviously is not taken in the right perspective. I'm sure none of the physicians also want to give an adverse result at any point of their career. So how are we to, I'm sure communication, you've been always insisting on documentation and communication from the beginning. I could see in every answer you are emphasizing that point. A truly unexpected death or unexpected adverse reaction in the process, what is the right way to handle the situation, sir?
I don't know in what, I can't imagine the example that you're talking of. A situation where you did not expect the individual to...
Sir, let me put very simple, sir, for discussion's sake. If we lose a patient on an unexpected grounds, we operate for a gallbladder, we operate for a normal procedure, we end up having a myocardial infarction, we end up having a pulmonary embolism and lose the patient. Ultimately, the patient looks up, we are at fault.
Yeah, these exceptional situations, it is difficult to give a general explanation.
Yes, sir.
I agree with you. The important features would probably mitigate the complication. One, the prior rapport that the individual has had with the doctor. The prior, not just the doctor who is operating, the other team members. Example, if it is the anesthesia person, or maybe if there is a vascular surgeon who is also assisting in the procedure. I have no idea. Depending on who are all the people who partake in the procedure, how well they have established rapport with this patient. And third, if there's any expensive or any serious investigation that has happened, that investigation report, that investigation procedure, whether that whether it is a radiologist or whether it is a nuclear medicine person, how much time they have spent explaining to the individual about the procedure. Very often, the treating doctor is the common window to the patient. It's a good idea. There are some exceptional situations wherein some expensive procedures are likely to happen or being planned. Concerned people also come and explain to the patient. So once a prior rapport is established, things go very smoothly. And an unexpected situation, the family is willing to take. Yes, you are right. What if, over and above that, if they go to... There are a lot of ways in which the doctor is protected in a situation like this. Because the peer review of the procedure, which is usually done. And it's quite likely if what has happened is something that not very uncommon, it could have happened in any other situation. And the doctor did not have a role to play in anticipating or guessing this. Peer support will be there. Most of the time, the peer support by way of experts who are called into these things can be very supportive. So I think the doctors need to feel confident as long as they are working on good faith. But then there are additional things, spending additional time in establishing rapport, information, documentation. can be a great deal of protection.
Thank you, sir. Thank you. Can I request Dr. Raman to give the closing comments before we call the session for a close, please?
Generally, Dr. Ishwar Murthy is there, but I see him, his internet doesn't seem to be very steady today. So thank you so much, Dr. Gangadhar. It was a real pleasure to have you on IAGS and answering all the questions. Though as Kanagwil said, you avoided everything that was not within your of mandate. So thank you so much for taking all the questions and clarifying things. We hope to see you some other time with as the NNC starts working more actively with time.
Thank you, sir.
And,
thank you for getting me an opportunity to
clarity on the issue.
wish you all the best. Let's hope.
Yeah, thank you so much. And thank you, Dr. Somsekhar, for being here. It's a real pleasure. And I see Dr. Sugar Baker is still logged in. So thank you very much, Professor, for your participation and presence through most of the program today. And thank you, Dr. Kanagwil, for Dr. Kanagwil is the key person who conceived and is implementing this IAGS program relentlessly for last 6 to 8 months. And this is the second last program of this academic session of IAGS. The last one will be on the 7th. So thank you so much. Dr. Ishwamurthy, are you there? Can you?
No, sir. I think he has some issues. He has asked us to call it a close.
Thank you so much. Thank you. Good night.
Good night, sir. Good night. Good night, everyone.
Good night.
Thank you, friends, delegates across the country and out of the country for joining us this evening. Thank you, IAGS, for providing this opportunity. And thanks to Shugabaka sir and team for keeping us in loop all the through and making this program a flawless one. Thank you, Dr. Somsekhar. Thank you, Docplexus. As usual, you rock. Nitin, Madhu, and the entire team, Sarvesh, who else who have been working behind. Thank you for giving us a flawless platform. And ladies and gentlemen, we look forward for an exciting program in the coming month as well. A very good night to you, and we wish a very pleasant and happy week. Thank you. Bye-bye.